Yeah. Cool. Thank you, everyone. We're back in a couple of minutes or so, 1 minute or so. Yeah. I'll put yours up full screen so that we can just take in delicious looking creature there.
Can I take mask off, Carl?
Yeah, you can while you're wearing mask.
All right.
Apparently it takes 4 hours to get someone COVID.
Yeah, that's exactly right. I'm rat negative, and our care points, we're acceptable. Are we back on? Good to go? Transmitting.
Yeah, should be good.
Morning, everyone. So today I'm going to pretty much do a crash course in snakes, spider bites, and I'm just going to touch quickly on the blue-ringed octopus. What I'll focus on today in the talk is I'm going to specifically stick to the eastern brown and Sydney funnelweb, just because in 30 minutes there's so much content to cover in this. And as you can see on the front, we've got a dangerous drop there lining up its prey. So as I said, I'm going to cover snake, spiders, the blue-ringed octopus. Late night kebabs will not be covered in this talk, and things that can cause you serious damage. This is the Snake and Spider Bite Clinical Management Guidelines, which were done almost 9 years ago now. This is the third edition of them. They're still the most current, and that's an excellent document for anyone wanting to kind of have a bit of a deeper dive into the topic. It doesn't cover specifically the toxins, but it covers the clinical syndromes of both snakes and spiders in New South Wales, and gives a very sensible algorithm to treat. So highly recommend that for any of the UK doctors who are wanting to do a little bit more around the toxinology in New South Wales. A lot of the data from that edition was taken from a project that was in progress at the time, and they're still continuing the Australian Snakebite project as we go. And this was a study done out of the University of Newcastle that went over 10 years, that was led by a number of toxicologists, including Jeff Isbister, who comes up a lot in tox circles. He's based out of Newcastle and has done a lot around snakes and spiders. But this was a really breakthrough study for essentially the 30 years before that. A lot of what we did around toxinology with venomous snakes and spiders, a lot of it was still quite low-level data and was what we thought was best practice. And then they actually started to get a proper database of 1,500 bites over time to collate what we thought was, well, at the time, what we thought was best practice and what currently is best practice now. So key highlights of that study, looking at that, was that they looked at deaths. And as you can see, from the number of deaths, the majority of the deaths occur with brown snake envenomations, and a lot of them tend to be in males and in rural areas. Something else that was came out of that study, which was really interesting, was that we looked at the VDK, which is the snake venom detection kits, and from that study we kind of realised that what we already knew, in that they were tricky and fiddly to do. If anyone's ever done one, I've certainly tried to do it on a couple of occasions, and it becomes very tedious, and it's best done by the lab. But the false positive in those kits is up to 35% in the study that they did, whereas they also had a misdiagnosis rate of somewhere between 5 and 10%. Interestingly, looking through that, you can see that out-of-hospital cardiac arrest comes up a lot with brown snake envenomations. There's a number of theories as to why people die out of hospital with brown snake envenomations, and one of them is that, when I'll go into a little bit further, is not necessarily that they're dying from a myotoxin or a neurotoxin or overwhelming Vic, which I'll go into in a second, but actually they think there might be a cardiac toxin in the brown snake venom that triggers a malignant arrhythmia that causes them to arrest. Interestingly, intracranial hemorrhage comes up quite a bit there, and unfortunately I've treated a patient who died of a tiger snake bite and was found to have an intracranial hemorrhage at the time as well. So snakes in New South Wales and the Sydney Basin. So in Sydney Basin itself, eastern browns you will see on the fringes, not so much in the urban metropolitan areas here. Red-belly blacks, you'll see them in my local park, so they're even down at the Sydney Park, just down the road from me at Sydney Uni, but they tend to be quite aloof. Death adders are rarer still in that they are very much like to keep a low profile. Tiger snakes we don't really see in the Sydney Basin in New South Wales. We see them out west, but they're more into the Southern Highlands, Victoria and Tasmania. Copperheads, which are related to the tiger snake family, tend to be in almost exclusively up in Kosciuszko National Park and around the alpine areas. The taipan, we do get coastal taipans, but they tend to be on the north coast. And sea snakes do occur off the coast, but there's never been a bite or a documented envenomation here. In terms of why snake bites occur, it's really very much dependent on the characteristics of the snake as well as the characteristics of the human. So behaviour, the anatomy and the environment plays a big part. And I'll go into that with the eastern brown. So a lot of snakes, a vast majority of snakes that you encounter really don't want to know us, and they've gone by the time they've even heard us, especially through vibration in the ground. However, if you do catch them by surprise, especially the eastern brown, it tends to kind of stay and fight, or it will strike you. It doesn't really give you a warning, it will just attack. The anatomy is important, mainly around the fangs. So a majority of snakes can't actually penetrate through a thick-soled boot. I was just saying before the presentation started, I had an encounter with a copperhead up in Kosciuszko 2 weeks ago, where he actually slid it over my foot, but the fangs are 2 mils, so they can't get through a pair of waders, they can't get through a sock, and they can't get through a boot. And then the environment plays a really big part, mainly in brown snakes that they've studied. So it's really interesting with brown snakes, especially where I grew up. We would encounter brown snakes in the orchards at the back of our property quite a bit. In cooler months, and they would usually be hibernating. And someone actually looked at this at the reptile park and said pretty much under 24 degrees, a brown snake is actually quite docile. You can approach it, but if you agitate it or upset it, it's still going to strike you, but you can get much closer. However, if the temperature goes above 24 degrees, even from a distance, they'll tend to be quite standoffish and aggressive. So something to note that in the winter months, brown snake bites tend to be less because they tend to be less agitated at the time, and most people are able to see the snake and back off and leave it alone. Characteristics of the human. So you've obviously got people who aren't educated about snakes being venomous. A lot of misidentification occurs, which I'll go into a little bit more. Trying to impress people picking up the snake. There was a gentleman who actually died on the Alpine Way about 3 years ago who saw a tiger snake crossing the road, stopped the car and picked it up to show his girlfriend, and he unfortunately died before the time he got to Cooma. And then there's people just unlucky having encounters, especially around farming property, lifting up corrugated iron tins. There was one, I remember there was a gentleman who had an eastern brown bite. He was the postmaster of one of the post offices out the back of a place called Wingham, and he opened the back where all the mail was sitting, and the brown snake had got into that. So as he lifted the letters out in the mail sorting room, it struck him on the face several times. And so that's just unlucky. And then, of course, drugs and alcohol, where people are intoxicated and disinhibited. In terms of clinical syndromes for Australian snake bites, the New South Wales guideline goes through talking about sudden collapse, VIC, which is the most important, neurotoxicity, myotoxicity, and then anticoagulant coagulopathy. Realistically, you can look at it into kind of most snake bites across the world, you can really categorise them into kind of 3 syndromes, and that's either the venom's a myotoxin, as in it affects your muscles and breaks down your muscles, it's a neurotoxin, so it's going to paralyse you, or it's a hemotoxin, so it's going to cause a procoagulant or an anticoagulant effect. Up the top, sudden collapse and VIC account for most of the deaths in Australia, and the sudden collapse, which is attributed mainly to the eastern brown snake, is that classic story of someone gets bitten by the snake, they have a sudden collapse, they go into an arrhythmia, there's syncope, and for those who actually survive that initial sudden collapse, they usually have recovery within a couple of minutes and then present to hospital, usually with a headache, vomiting, nausea. VIC, which is venom-induced consumptive coagulopathy, is pretty much the most important syndrome that we see, especially in eastern browns and tiger snakes, which account for a majority of the bites. And that's where you actually trigger a procoagulation effect within the blood. So you start to get clotting of the blood, but because you're clotting in the blood, you start to consume all of your products, so they start to bleed elsewhere. Neurotoxicity is important, but tends to be delayed. I've only seen one case of neurotoxicity, which was in an 11-year-old that got bitten by a rough-scaled snake a couple of years ago, but she was a late presentation and she was actually in full-blown Vic at that time. Myotoxicity is another thing that you tend to see around delayed neurotoxicity, usually because of paralysis, long lies, but there are some snakes that cause mytoxins. In terms of anticoagulant coagulopathy, this is almost exclusively seen in black snakes. So classically your red-bellied black snake, and also in the Northern Territory, your king brown, which is called the mulga snake, which is actually a member of the black snake family and not related to brown snakes at all. TMA is essentially what's going on at a cellular level, where you're getting hemolysis of the blood and damage to the capillary bed. So if someone does a blood film, you're going to see lots of red cell fragments, and that's usually what ends up causing you to require dialysis in the context of combined myotoxicity and rhabdomyolysis. Systemic symptoms of nausea, vomiting, abdominal pain, diarrhea, diaphoresis and headache are really non-specific, and you see that across a lot of venomous snake bites, especially ones that we don't consider life-threatening or you can just monitor for as well. Going through, I'm not going to go through the whole table, but just touching on the brown snake, Vic, which I said is really important. As you see, neurotoxicity is rare and mild, but going right to the far right of that table, about a third of brown snake bites have a collapse. So, and then cardiac arrest is kind of a subtext of a point of that. Tiger snake groups, Vic is most common, but they also do, they can get neurotoxicity. The death adder, which we do see up into the Blue Mountains, and there's been a couple of death adder bites in the last kind of 20 years, but pretty rare because they're an ambush predator that likes to keep to itself, is a clinically differentiated syndrome in the sense that it's going to cause both skeletal and autonomic muscle paralysis, and so that's a rapidly descending flaccid paralysis, and I'll talk briefly about a case towards the end that Retrieval looked after 15 years ago now. And then the taipan, which we thankfully don't see down this far south. So the taipan one of the things that makes taipans particularly nasty is that they cause a neurotoxicity as well as a Vic, but they have long fangs and they're generally quite an aggressive species of snake. So they've got a 9mm fang. And so they penetrate clothing, even if you're working in the cane fields or wherever you are on the north coast. But they tend to be standoffish, so they won't be perturbed or disturbed by you coming in their way. They'll just bite you. Eastern brown snake. So, touching on that, the eastern brown is the most commonly encountered venomous snake in New South Wales. It accounts for the most deaths in Australia as well. In terms of identification, the way that you can kind of pick a brown snake is they usually have a small head, that it's the same size as the neck. You can they see that they have this confluence with the neck. But saying that, I'll go into it as I said, but the fangs can go up to 4 mil. They tend to be about 3mm, so we're still talking very small, which is why a lot of the bites don't penetrate, thankfully. And then for a bit of cheek, the way that you're actually meant to fully identify or can only accurately identify a species of snakes is to actually look at the mid-body scales, and then the anal scales is what the hepatologist will say is the true way of identifying a snake. And I can remember a story of a patient in the Northern Territory who was very unwell with a brown snake bite, and on the phone the toxicologist actually asked, he goes, "Did you look at the anal scales?" And we kind of we're a bit past that, mate. Now, colour is really important. I've actually borrowed this off Lee, who took this from the guys at the reptile park up at Summersby. And these are all eastern browns. And so the fact that it's a brown snake is a bit of a misnomer in the sense that these are, I think it was like a 5-kilometre radius these snakes are from. So they're from the same area in the same part of the state, and they're all a different colour. And certainly where I'm from up the coast, a vast majority of our brown snakes were that bottom left, almost that olive colour. So we're always told, don't think it's just a tree snake. It could well and truly be an eastern brown, and they would even be almost like a real green about them. But you can see that they change quite a bit, and they vary in their colour. Things that make brown snake bites common too from a behavioural point of view is that they're diurnal feeders, so they feed in the day. They have a diverse habitat, so they'll go from anything from urban grasslands to rainforests. They thrive in farms. They tend to eat frogs, reptiles and reptile eggs. And the thing is that they're nervous and easily agitated when surprised. So they do two things. They'll raise their head and then they'll coil into an S shape. And I don't know, has anyone in the audience ever come across a brown snake and had an incident? No. So like every now and then, it's usually the dogs on the properties that get bitten all the time. They go around and sniff the snake, and I've unfortunately witnessed the neighbour's dog get bitten by one of these, and they actually coil up in it and they just strike. We talked briefly about the temperature characteristics before. Dry bites are highly variable with brown snakes, thankfully, so they will often strike and not envenomate. It's really hard to differentiate a dry bite from an envenomation in brown snakes because a vast majority of brown snake bites do actually present asymptomatic. They don't hurt. People generally feel a scratch or a mild bite, and they don't actually know that they've been envenomated, and then the syndrome starts to develop. It's a highly potent toxin, so the lethal dose, LD50 of the eastern brown, as you can see, it can kill 200,000 mice in one bite. So signs and symptoms, majority are minimal. We talked about that earlier, cardiovascular collapse or a syncope. Headache, nausea, vomiting, painless bleeding. And the two cases I can think of, actually the two recent cases that I've dealt with in the last few years. The last case I dealt with was a man up in Nimbin, if everyone knows that place. He went out to go to the toilet in the early hours of the morning and got back in bed, and he said to his wife, he said, "Honey, a mouse bit me." She said, "What do you mean a mouse bit?" And he goes, "Well, I assume there's a mice, we have mice on the thing, but I was on the porch and I felt a little between my feet, and yeah, a mouse bit me." She goes, "Honey, mice don't bite in Australia. Turn on the light." And he's like, "Oh, I feel okay." And then he started to get a headache and he started to be nauseated. But he came to us at about 6 a.m. in the morning and looked completely normal. We had a pressure mobilisation bandage on him, and it wasn't until we actually did the bloods that we found out that he was in full-blown Vic and had quite a severe envenomation from a brown snake. In terms of the painless bleeding as well, that's actually quite common because you're already starting to get anticoagulation of the blood. And a colleague of mine, when I was in Broken Hill, actually, between Cobar, had a woman come in who went to the toilet on the side of the road, didn't know she'd been bitten, and actually thought she was menstruating in the car because she was sitting in a pool of her blood. And she looked down and she was bleeding into the car seat, and they were like, what's going on? And when she took off her pants, she had a bite mark on her bottom, and she was just bleeding, consistently oozing out of the bite mark, which also turned out to be a brown snake, and she felt absolutely fine, but she was starting to develop signs of Vic as well. So in terms of early management, this is just broadly with snake bites in general. So pressure mobilisation bandage is the key, and then splinting. So traditionally would say that a majority of your snake venom travels through the lymphatic system, and then a small amount does travel through the blood. And I think previously it used to be said that it was purely lymphatic spread, but it travels through the blood in some of it will go through the venous drainage system. But the PIB does save lives. It is effective. So pressure mobilisation bandaging, and then also splinting, so making sure that the patient doesn't move that affected limb. Early large bore dual access is really handy if you're going to find out that you're treating an envenomation. And the reason is that one of your lines is going to be for your antivenom, and the second line is going to be as a sampling line, but also because of the quite large rate of anaphylaxis, you're not going to give IM injections once you've got demonstrated signs of Vic, because you get a compartment syndrome risk. And certainly I have seen it where we had an anaphylaxis from snakebite, antivenom. We gave the IM injection and then they just blew out this huge hematoma, which we then had to refer to the plastics team. You've got examination. We talk about workup and then antivenom. So in terms of examination, you're going to be looking for neurological signs, which, as I said, tend to be rare, especially in eastern browns, but ophthalmoplegia, ptosis, bulbar weakness. Evidence of bleeding is going to be something that's going to be more prevalent. And then examination of the bite site, looking for fang marks. And sometimes I find it incredibly hard to even see them. Even when the patient's pointing to it, you're kind of looking for that bipunctum of the bite site. But as I said, we're dealing with 2 to 3 mil fangs in some of these people who have usually a lower limb bite, and they're usually tradies or someone who works outside. So they've got cuts, scratches, marks all over them. So they kind of point at a couple sites, and it can be quite tricky. PIBs, just to quickly talk about them, they say you should start below and then go across the site and come back down. There's a slightly different mantra around funnel web bites, but we're talking snakes at the moment. So it's essentially you're going for the whole limb and all the way down, and making sure you try and splint that limb afterwards as well. A guy called Bart Curry, who's a bit of a famous guy up in the Territory, along with Jeff and a medical student who, I don't know what Elizabeth's doing now. They went and actually looked at pressure immobilisation bandages, not using the proper PIBs, and just looked at when you did it with a crepe or another type of bandage. It was a quite interesting study. They got the ambulance service to put these on, and then they got the ambulances to drive around Darwin to simulate them taking a patient from the countryside to the hospital, and they found that essentially crepe bandages were inadequate, and that a vast majority of those bandages were not offering pressure immobilisation by the time they arrived in the hospital, and the patients move and they slip. Investigations, so as I said, the FBC plus the blood film, which is going to show some hemolysis in that Vic. UEC, CMP, CKs are going to show your myotoxicity. INR, D-dimer, fibrinogen, and APTT. Now, usually when you see these envenomations, nothing's happening by halves. They may be clinically asymptomatic, but you'll see the D-dimer will almost certainly be above 10 already, even within 30 minutes, and then your fibrinogen will rapidly go down. And the last one I treated, which was that man who got bitten in Nimbin, his D-dimer was greater than 20, and he had an undetectable fibrinogen, but he was actually asymptomatic at that time. He felt absolutely fine. Whole blood clotting time is not really done anymore. It's kind of tedious, so some places will advocate you just have a whole blood clotting time and start the stopwatch, and if it's delayed, well, then you've got signs of Vic. And then the SVDK, which you can use either urine and the bite site. And look, they're really tedious. They should be sent to the lab. If you're really unsure, you can use them. But has anyone ever had to use one? Have you used did you use in Darwin?
No, Gosford.
In Gosford, what about you?
Yeah, Liverpool.
Yeah.
They stopped.
Yeah, and that's the thing. And you know, there's the best SVDK story I heard was from 2 Kiwi doctors working in Port Macquarie, where a guy came in with a snake bite. They did the SVDK and he came up positive for both tiger and brown snake, and they were really panicked. They're like, what do we do? What do we do? And one of the nurses came in, they said, we've got the snake in the bag. So the nurse looked in the bag and it was a blue-tongued lizard. So he was, yeah, they were freaking out. They're like, and the guy was fine. He went home. Group and screen's important because you might need to give blood products, layers with tox. And this is kind of a point. The point of care INR and coags at the smaller sites using the EPOC machine are not really accurate, and you can't use them. So they need to be in a proper hospital. So the treatment decision comes to knowledge of snakes in the area, the clinical syndrome defined. We talked about SVDK, liaison with toxicologists and local protocols. So, for example, Lismore's local protocol, they don't do polyvalent. They just do 1 vial of brown, 1 vial of tiger. And that's if they don't know what's happening, and that's just what they go ahead with. That's straight from what ETG has, but also this policy has. And it just talks about, well, if you haven't got an envenomation, when to look at them, how long do you leave the PIB on for? Essentially, you should leave the PIB on, do your bloods. If there's no sign clinically of envenomation and biochemically of envenomation, you can take it down, but you need to observe them up to 24 hours in some cases, depending on what the snakes are in the region, and you can just repeat bloods with serial examination. Absolute and relative indications to antivenom, and you've got abnormal INR with clinical syndromes, evidence of paralysis. So one of those caveats is that the death adder is not going to show biochemical derangement. You're just going to be treating that on spec, given that you're going to see a descending paralysis. I was thinking about retrieval specifics if we're out west and we're dealing with snake bites. Pretty much any level 1 emergency department carries monovalent and polyvalent venom. Antivenom, and so even your tiny little places will always have something in the fridge. So if we need to get antivenom brought to the aircraft or ambulance, Even some of the multi-purpose centres will have them. So it's pretty widely available. And I think it'd be a case like if we're in a pre-hospital or far west setting where we're not going to have access to biochemical treatment, but we strongly suspect an envenomation, you just start the treatment. They should go to a centre with antivenom. With ICU facilities, they generally get monitored in the ICU. 1 vial is the treatment. It doesn't stop. It doesn't reverse the VIC, but can prevent intubation. It can reduce renal complications and myotoxicity, and that's certainly the case with brown snakes. Now, there's quite a number of complications of antivenom because it's made with horse blood. There's a 5% incidence of anaphylaxis, and the way that you treat that anaphylaxis, just going through that, is that you don't give IM injections because you're going to talk about that compartment syndrome. You just start an adrenaline infusion, and you can do that peripherally. Cutaneous reaction is quite common, and then you have a 33% delayed onset of serum sickness. Running through complications, it's major bleeding. Well, you're going to give blood products. If you've got microangiopathy and they need to be dialysed, you dialyse them. If they're showing signs of neuromuscular weakness, you're going to intubate them. You're going to use an adrenaline infusion for anaphylaxis, and you can have outpatient prednisone for serum sickness. This was a case that I was involved with a couple of years ago. This is an 11-year-old. She got bitten by a rough-scaled snake, which is a tiger snake family. She actually got bitten putting the chickens away in her home up in Mullumbimby. And told her mum that she'd been bitten by a snake, and she'd had a bit of a history of being an 11-year-old and telling stories. So her mum didn't believe her and put her to bed. And she came in complete hemodynamic collapse and was intubated on arrival the next morning at Lismore. And she had all the complications. So she was actually in complete VIC, but she was profoundly neuromuscular weak and had also developed quite bad rhabdomyolysis, probably from long lie, but she ended up in Brisbane, and she was on a ventilator with a trachea for 19 days and had a 53-day hospital admission. But yeah, she couldn't even open her eyes, but I think that was because she was actually peri-arrest as opposed to profoundly envenomed. There's a little bit of 1 vial controversy floating around. I don't know if anyone's read that in the news about cases in Victoria and South Australia, and Tasmania, where large tiger snake envenomations have been treated with 1 vial and the patient's actually gone on to die. So it's almost like the Brisbane line. The East Coast guys think 1 vial's enough, and I actually spoke to I texted a toxicologist about this yesterday, and he said I still advocate 1 vial, whereas if you go pretty much to South Australia and across to Perth, they would say that treat with 1 vial, but be ready to give multiple vials, especially in tiger snake envenomation. So at the moment, I would say in New South Wales, we're still going to do 1 vial, and we're going to talk to Tox if you would think that you needed more. How am I going for time, Laura?
A couple more minutes.
Okay. This was one that was retrieval from 2006, which was a man that grabbed a blue-tongued lizard that actually was a death adder, but he was highly intoxicated and was bitten 5 times on the hand and arrested. And I was talking to Shane about this, who had just started as a consultant, and it was a UK registrar who had arrived, and I think it was 2 weeks after they'd arrived in Australia, getting called to a cardiac arrest for a death adder bite. A bit of a difference, but you can see. Snake bites, as I said, sea snakes don't really occur in Australia, and they generally call on the fishing trawlers when they bring the long lines in, or the nets. The snakes are caught in the net and they bite, and they're almost certainly fatal, highly toxic. You're well and truly away from any medical facility, so they've got a pretty high death rate. Sydney funnel-web spiders, I'm going to quickly run through. So funnel-web species, there's actually 40 species of funnel-web in Australia. We talk about Sydney funnel-web, which is all the way from Hornsby down to Wollongong. All the way from Newcastle down to Wollongong. That's the kind of classic Sydney funnel-web. It lives in your garden. It's about 5 centimetres long. It prefers a moist environment. Something you notice in your garden, if you've ever seen the funnels, you see a lot of funnel webs that aren't actually funnel web spiders, and this is nice and clean and tidy. That tends to be a trapdoor spider, but the kind of pathognomonic dwelling of the funnel web is it's got these long spindly silk fibres on the burrow, so you can be sure that that's going to be a funnel web as burrow. In terms of bites, we see this quite a bit. I mean, Carl would see it at beaches as well, all the way up to Hornsby and Newcastle. Gosford has the highest bites in Australia. Is that you get a lot of dry bites with the funnel web, and one of the things that you tend to know is if they have envenomated is that the bites actually, an envenomation bite really hurts because it's got deep fangs and the pH of the venom is acidic, so it's like being bitten by a bull ant. If you experience that, it's that really deep formic acid kind of pain, so they come in a lot of pain. Lots of differentials around Sydney. There's trapdoor spiders, there's mouse spiders, there's a thing up near Gyra, and then there's the black house spider. Going through this, so the guy on the left is actually a really common spider, which is just a trapdoor spider, and the way that you can tell that he's not a funnel web basically is that he's not dressed in an Armani black suit. He's in a bit of an old casual tweed, and he's got little boxing gloves on. That's the way that they kind of say right at the front on the front too. That's a mouse spider that looks like it belongs in Spider-Man, the one on the top. And then the two brown guys are actually the Hydronike species, which are the tree-dwelling funnel webs that you see up the north coast. So they're not actually funnel web spiders that live in the ground, they actually live in the trees, and they come down during summer after rain. The males will go looking for a female burrow. And then the other one on the right is also a mouse spider, which you can see, they all look kind of similar in some regards. Signs and symptoms of the funnel web bite. So you're dealing with robusta toxin, which is going to depolarize your acetylcholine receptors, so you're going to get a mixed picture, but you get a cholinergic and adrenergic excess. Patients are in pain. They look terrible. They tend to be sweaty, diaphoretic. They've got paresthesias, but in terms of real envenomations, the kind of key things is you start to see muscle fasciculations, especially around the tongue. They get muscle spasms, and then they quickly develop pulmonary edema, and they're in a lot of pain because the bites hurt. In New South Wales, we have the big black spider protocol. If it's big, it's black, and it's bit you, you need to put a PIB on, observe for 4 hours, and then you can take it down after 2 hours. There's no sign of envenomation. They do dry bite a lot, funnel webs, thankfully. And then envenomation dose. So differentiating from a snake bite is that you will give 2 vials, and that it is dose dependent, especially if you've been bitten up in the northern rivers or north of Newcastle and it's not a Sydney funnel web. You'll be looking to give more vials because the species, we make it for Sydney funnel web, but the Hydronike or the tree-dwelling funnel web species is not quite the same venom, so they usually need a little bit more, but it's still effective against that. Ventilation and PEEP, atropine, tetanus, inotropic support, and strong analgesia. So certainly the ones that I've only been involved with one of these recently, and they ended up getting intubated, but they were fine the next day, and they were extubated, taken away from the kids' hospital the next day, and the family were upset that the child, the daycare were the ones that copped most of the scorn of the parents. Milking and antivenom, I know we're running out of time, but really interesting. No one's actually died since a guy called Sean Sutherland introduced antivenin back in 1981, and that was a really, really hard thing to do. Snakes were much easier. They were using horse's blood to make the antivenom, and they couldn't stabilise the robusta toxin using horse's blood, and they kind of faffed around and fiddled, and eventually made the funnel web antivenom using rabbits. And I was going to play a quick video from the reptile park. You got how long we got? Am I way over?
No. Just keep going.
Okay.
I'm popping in out, so you got
okay.
time.
Ooh, will that play sound, Carol?
It's off my computer, so.
Whether it's sending the audio through, the best way is to choose to send the audio to the actual. Let's go to. Give me 1 second on this line.
Spiders do come to us via public donation. Now, in order to actually catch the spider, what you will need is a large jar like this one here. Now today we've got this female Sydney funnelweb spider reared up in front of me. If the spider is stationary, not moving, what you can do is pop your jar next to the spider, keeping your fingers at a safe distance of course, and then you can use a large spoon or maybe even a 30cm ruler to gently encourage the spider into the jar, just like that. Very easy. Now, if your funnelweb spider is moving, it's a bit of a different story. What you want to do is take your jar and very simply pop it in front of the spider, like that, and it will walk straight into it. Now that you've safely captured your funnelweb spider and it's contained in the jar, what you want to do is take a little bit of damp soil from the garden, or perhaps even a damp ball of cotton wool, and pop it in the jar with the spider. This will provide your funnelweb with a little bit of moisture inside the jar and will keep it nice and happy and healthy until you can either get it to one of our drop-off points. We have them as far south as the Sutherland Shire and as far north as Newcastle, or of course you can drop your spider directly to us here at the Australian Reptile Park. Once your spider's in the jar with a bit of moisture, of course, pop the lid on to finish off. Thanks for watching, guys. I hope this helped you out a bit. And of course, if you are catching a
to get a spider, it's quite a so if you do work at Hornsby or Gosford, you will see that there's people who regularly drop them in, and so Hornsby has actually its own cupboard where we drop the spiders in. If you've worked up there, and they need about 120 spiders to make one vial of antivenom. So that's why they really encourage the public to bring them in. And guys, like it's pretty crazy. Like you see people just come in with milk. They usually put them in milk bottles or like at the bottom, and they just come in. They're like, oh, hey, I've got a funnelweb. And you're like, oh, yeah. And then the triage nurse just pops in its little thing. We have pre-made cotton balls of saline, and then just pop it in. You're like, oh, it's good. That's good. Okay, all done. Hold on. I've lost my presentation. Oh, yeah. My poison script. There we go. Yep. And then I just briefly wanted to talk about blue-ringed octopus. Did everyone see the video that I sent in the group chat? I put it in Retrieval 19. That was actually courtesy of George Davison. He told me I had to cite him. That was just him down at Narrabeen last year, taking his dog for a walk. So if you see the video, I've got it on the thing. And he just saw one in the rock pool floating along there. So they're actually, I don't know if you've come across them, they're actually really small. You always think they're quite large, but they fit in the palm of your hand. They only go that beautiful blue colour when they've been threatened. And they're pretty prolific all the way up the coast, up into Southeast Asia and even into America. The toxin that's from them is a thing called tetrodotoxin, which blocks sodium channels. And what's interesting is it's the same toxin that you find in cone snails and a lot of your marine toxins that cause paralysis. And the blue-ringed octopus doesn't actually make the toxin. It's just found in its body and beak, along with the cone snails, and it's due to what they call symbiotic bacteria that produce the toxin. So it's in a number of these marine animals. So it's actually circulating. So it's been an evolutionary progress. It's a painless bite. It does respond to pressure immobilization bandaging. There isn't an antivenin manufactured for it, so it's about early ventilation and mechanical support for that. And I don't think Sydney's actually had to treat one for 20 years. I don't think there's been a bite. The only marine envenomation that I've treated apart from box jellyfish is a cone snail, which is a similar toxin, and they had bulbar palsy and required intubation at that point. I was going to show another video, but I think we're a bit short on time. You got a video? Okay. Something that's quite interesting that I didn't go into with pressure immobilization bandaging is that with pressure immobilization bandaging, especially talking about funnelweb bites, is that when they were looking at pressure immobilization bandaging for spider bites and snake bites, that they noticed that the robusta toxin of funnelwebs was actually pressure labile. So by giving a decent amount of pressure over the bite site was actually causing some of the robusta toxin to break down, which is a little bit different to the snakes. The snakes are just trying to stop it getting there. But actually, when they talk about immobilizing below and above the bite site with a spider bite, they often say put a bit of pressure on the actual bite site itself, go distal, then come proximal over the site as well. And they demonstrated that on spider monkeys of all animals, that they actually managed to keep spider monkeys alive by just pure pressure mobilisation bandaging of the limbs.
If you're a woman who owns a business, then you need a virtual assistant. And not just any virtual assistant.
She thought it was just a cute little baby octopus she was handling, and she put a video of it on TikTok. And only then did she find out that that cute critter is one of the most deadly animals in the ocean. One bite, and you could be dead in minutes.
Wow. How adorable. What a cute little guy.
I saw it in the water and I thought, my initial reaction was to just pick it up.
And then you find out that little tiny creature could have killed you and over 20 people.
Talk about a shocker.
Kaylin Phillips had no idea the creature from the sea she and her friends were passing around on a beach in Bali is one of the deadliest on the planet. Let's eat it.
No, don't say that. I posted the picture on my Instagram story and I got a couple comments like, hey, do you know that this is the blue ring octopus? Right over my head. No idea.
She found out it was, in fact, a blue-ringed octopus with enough poison to kill more than 20 people.
20 people? It's been radicalised. It's going on a spree. Played a lot of video games, got in the wrong crowd at school.
So to speak, right? She's very lucky that nothing happened to her. These tiny little gulls.
So last year, I saw a child in the ED and the mum rushed the kid in, and it was very fortunate. So she picked up a shell on the beach at Balmoral and put the shell in her one-piece swimsuit because she was collecting shells, and then she pulled the shell out and the blue-ringed octopus had been hiding in the shell, and so she had sat it against her tummy the whole time and then came out. And because the bite on the beak of them is so small and often painless, we ended up sitting her in the ED for 6 hours and watching her, and she was fine. But it was very lucky because she actually held the blue-ringed octopus against her in her cosy in the shell for a good 10 minutes, and it was when she actually got out of the water she came out and brought it out. So that was a fortunate outcome. Look, guys, I've kind of raced through a lot of that. Are there any questions?
Just one question in relation to your snake venom.
Yeah.
Because obviously I've never given anyone a snake venom, but I've heard some stories, and the idea of if you have anaphylaxis, you often remove the trigger, but I understand obviously you need to give the whole dose.
Yes,
so,
that's true.
So what are your options? And then you've got the people that come back time and time again, I suppose more rural, having been bitten before and having had venom before, and I just wonder what people's experiences with that. How often now when you're giving the venom do you draw up your vasopressors, or what do you have around, and just a bit about that.
Particularly if you're given polyvalent, you should definitely have some adrenaline ready to give because it is much more common. And if people have had it before, that's a bigger risk factor, particularly snake handlers. Snake handlers sometimes will refuse antivenom because they've been treated so many times that they just don't feel it's worth the risk. That's been my experience. But yeah, it is high enough that you should be prepared for anaphylaxis. The treatment for anaphylaxis of a true envenomation is to slow the infusion of antivenom down and continue it, but not stop it. Cool. Any other questions? We had one from the WhatsApp group. Was what about like TEG as a means of measuring people's coags? Is there any information about that?
Actually, it's interesting. I actually asked Lindsay Murray about this yesterday, and no one's done a TEG on it.
Okay. It should work, though.
Of things. So I mean, you're going to see it's going to tailor. Yeah. It's going to tailor your factor replacement. But the only snakebite I've ever given or considered blood products in was a woman who was a delayed presentation from a tiger bite out west of Coffs Harbour, and she was anticoagulated on dabigatran, and so she was in real trouble, and unfortunately she died. She was just bleeding from everywhere, and actually when the ICPs intubated her pre-hospital, they lost the airway because of so much, even just gentle soiling of the airway. She just bled out. And it was awful. Yeah.
Nasty. And then there was someone asked, do we see enough envenomations here to carry antivenom? We, a long time ago in the history of retrieval, actually had antivenoms on bases, but it never got used and just went out of date and got thrown out. So we don't use it anymore. We don't carry it because we know that where we can get it, and there's antivenom at all the hospitals, and the ACC have a list of all the hospitals and how much antivenom they have, so that's what we do. It's just not worthwhile having very expensive antivenom sitting in a fridge that goes out of date and never gets used. Final quick point is just the one vial theory is quite interesting, one vial controversy. Isbister did a study where he measured the amount of venom left over after giving a vial of antivenom in hundreds of patients, and there's no venom left from a single vial. There's way more antivenom in a single vial than any snake can give you a bite of, and that, for that reason, recommends a single vial. The problem was that in particularly the distant past, people would see a particular tiger or brown snake, and they would measure their coags, and the coags would be terrible. They'd give antivenom, and the coags would still be terrible. You ever see the problem with that is that the antivenom just mops up the venom.
Yep.
It doesn't fix your coags because they've already been used up. So you actually have to replace their you have to give them FFP and cryo to fix their coags. And if you don't do that, then they continue to remain anticoagulated, and no amount of antivenom will fix that. So that was kind of maybe a misunderstanding of the purposes of antivenom, but it's very rare to need to give people antivenom in Australia now, and just because people are generally well brought up, and the only people I ever see is people who tried to kill a snake with a shovel whilst drunk. That's pretty much
It's usually barefoot too, and a few beers.
It's massively intoxicated, try and kill the snake, and the snake wins. Any other questions? Cool, well, thank you very much. That's a great summary, and we'll record that and put it up on the website. Thanks.
Thanks, guys.
Good job. Video. Okay, we need to clear up.